So the objective of my talk is to explain a little bit about what we do at the center and show you a few case studies and some of the results of our work. Now the center is located in a really interesting place. So we're actually in Toronto General Hospital, surrounded by 4 other main hospitals in North America and right across the street from University of Toronto. So the reason why this is unique is because we are at the root of clinical action. Right? So we're really in the environment and are able to identify problems, create solutions, and then implement them. So we also have the largest usability lab in all of North America. So this usability lab contains 2-sided glass where we actually conduct testing on all of our software products. So, I work with software developers, graphic designers. I'm an engineer, mechanical engineer. We also have clinicians, nurses, psychologists, you name it. So we are trying to develop solutions to influence care of the patient in their home, bedside, in the hospital. One time we actually did the whole fuselage of a military helicopter to see how the vibrations would impact the technology they were using. Right? So we're really able to create the environment and then test the solutions. Now, at the crux of all of our products is the user-centered design process. Is anybody here familiar with that process? Okay, yeah, so there's a few, maybe like 5 or 6 hands went up, right? So that process is actually stems from marketing. So it's about getting user feedback, and we really believe in this, and we implement this at each phase of the product development. So this can be from understanding what the problem is, going into the hospital, the ERs, shadowing patients as they're sitting at coffee shops using their phones, which is actually the topic of my conversation today. And then when we develop the software, we bring them back in and test at each phase of the development. And then we launch it. So now something you'll see here is that, this one. So, once it's deployed, what happens? So we are trying to understand this better. And somebody was talking about open data. Similar to that, we're trying to gather data post-deployment and then feed that data back into the cycle. And we'll look at some examples. So now, the focus of my talk is how we can use mobile health, so this includes feature phones and smartphones, to deliver more effective care. Now in Canada, 60% of all healthcare spending is spent on these big 6 chronic diseases. We can add a 7th, which is cancer. 1 in 3 Canadians has 1 in 7 of these conditions. So that's about 9 million people. And now, as you can imagine, with the big wave of the population, reaching the older demographic range, the aging population, this problem is becoming even greater. How will we sustain the healthcare delivery for these patients? So now bear with me, I know this seems a little academic. Keep in mind I'm from a research center, so that's how I do my diagrams. So if we look here on the y-axis, there's quality of life, and on the x-axis, there's cost of care. The traditional healthcare system was built to deliver care in the hospital. So this was before we had huge populations, aging populations that were sick. Now imagine these patients who are coming for every little problem to the hospital. This is not sustainable. Look at how expensive it is. We're looking at $1,000 per bed for basic care. This is not for somebody dealing with fatal conditions. So now there's an opportunity to use technology and move into this upward quadrant where we're supporting the patient in their home, where they're happiest, surrounded by their loved ones, and really improving quality of life while decreasing the cost significantly, right? So as I said, the topic of my conversation with you today is mobile health, also referred to as mHealth. We know that, and people have emphasized this throughout the day, that phones are everywhere, they're personal, they're with us all the time. So this is an opportunity to deliver healthcare to you in the situation, right? So we're talking about behavior change. So there's this aspect of psychology behind this, right? So 68% of the world has a mobile phone. That's incredible. And in the US, about 1/3 of the US has a smartphone. So what differentiates a smartphone from a feature phone is these advanced capabilities. So the accelerometer in the phone, using GPS allocations. Basically, a smartphone is a mini computer, right? We can embed algorithms in there, and we'll get into that later. So now there was a boom, right? I would say in the late 2000s, early 2000s, excuse me, when the iPhone came out specifically. And there are over 15,000 health and wellness apps. So for somebody who's really sick, and you go onto the Apple Store or Android store, I mean, how do you know which one is actually clinically relevant? Like somebody said, maybe it's somebody in their garage who built something, which is great, right? That's how some great ideas are born, but how is this actually going to help my health? So an example of how this can be used. It's okay. If you can fix it, I'll continue talking so I press this button.
Okay.
So an example of how it can be used is, there's two ways. One way is that the patient or the user is using it. That's fine, yeah. There you go. So one way is that the patient is alone with the device, and the device has an algorithm in it that's smart enough to give them feedback. The other way is that it facilitates communication with a healthcare provider, meaning that I enter information into the phone sends it to a data server, and then communicates it to my clinician. And then the clinician can use the same reverse path to get the information back to me. And I'll clarify this showing you some concrete examples. Now this is a patient, his name is Joseph, and he has advanced heart failure. So he's using a Honeywell system here, which it looks kind of caveman-like, but at the time it was very advanced. And what this does, it allows him to every day upload his vital signs, which is sent to a clinician who's on standby. Then the clinician looks at these vital signs and then phones him if, an emergency situation is occurring. And then he continues and follows the instructions given to him. My question to you is this really self-care? Right. So it's not self-care, right? Because sure, he's gaining awareness by taking these measurements. He'll see that his blood pressure is elevated, his other vital signs are out of target, but he is not able to take care of himself. Somebody else is telling him what to do, right? The second problem is this caveman system is ridiculously expensive. That box you see on the table is $5,000. Not to mention the amount of money we're spending on the clinician who's sitting on the other side reading this data continuously, right? So with the amount of patients going towards that older demographic, critically ill, right, we cannot spend that kind of money on technology. So we created a system on the BlackBerry phone. The study is about from the 2001. And we followed the user-centered design process. So we brought in these older patients. There's a prejudice that older patients can't use mobile technology, and this is false. We have to include them in the design. Make sure the fonts are large enough, that the system is binary, yes or no questions, and it can be used. So the system was highly automated, and if you see on the left-hand side, there's a wireless weight scale, which is important for them because they tend to get dilated. There's also a 2-lead ECG and a Bluetooth blood pressure cuff. So we did a clinical trial for 6 months. So one group had their typical system. The other group got our system. And although these are a bit advanced values here, all to say is that the group that didn't have our system saw no change. Keep in mind, these patients are maybe 5 months away from dying, right? So no change that's critical, right? But the group that had the system was better able to manage their care. And they saw a significant improvement, as you'll see 7 points on the scale for self-care. Now this is another example of hypertension and type 2 diabetes. Now hypertension is interesting, so that's high blood pressure, because it's pretty non-symptomatic, right? I'm pretty sure maybe like 1/5 of the room has hypertension here. You don't feel it every day, right? So how will you manage your condition? Typically people use this machine on the left that sits in the bottom drawer somewhere. Your doctor tells you, hey, you better measure, so you measure once, you forget about it again, right? So we decided to couple that with another BlackBerry system that used a Bluetooth blood pressure monitor. And we conducted a study to see what would happen. Again, after a year this time, the group that had the traditional system saw no change, and the group that had our system saw a decrease in 20% risk of cardiovascular disease. That's more than certain medications can yield, right? So what was the mechanism there, right? They received no additional medications and no extra attention from their physician. So the mechanism was they took their reading, realized there was a problem, and took their medication, because these people tend not to take their medication. So now we're seeing that we can use a smartphone to get people to better adhere to their clinical treatment. That's huge. Now this is my most favorite case study. It's a very problematic age group, right? Talking about teenagers, it's hard enough to get them to do anything, right? So now, I remember, I was once one. So let's talk about somebody who has type 1 diabetes. You're diagnosed at the age of 10, maybe 11. You have to monitor your blood glucose 5 times a day, minimum. That means you have a little machine about the size of this that you take with you everywhere. You prick your finger for a blood sample, measure it, and based on that, adjust your eating patterns, your exercise patterns, and then inject yourself with medication. 5 times a day, every day for the rest of your life. You're asking a teenager who goes to school in a high school environment to do this, right? Currently, the tools given to them look something like this. It's a paper-based document. They're asked to fill out 5 readings every single day and then bring it to their doctor. Now, the physicians are telling us that this isn't helpful at all. The reason is that, firstly, most of these readings are false, right? They feel bad, they don't do it, so 5 minutes before the appointment in the waiting room, they're frantically scribbling in all these readings. So then the clinician can't really adjust their care because these readings are false. And also, while the person is entering this information, they're not thinking about what this means. There's no education there. There's no actionable education. So now, while there are these people developing electronic versions of these forms, it's still not effective. I'm not saying that's a complete waste of time. Look, it's better to carry around an app on your phone than this paper, right, which is completely useless. But there's still no feedback. So we realized that we could create a mobile system that had to be fast and discreet, had to deliver some kind of education, and really encourage them to manage their own care at a very young age. And it had to be wireless, right? None of this wire stuff, right? I'm fed up of carrying around my phone charger, laptop charger. I don't want a blood glucose charger or transmission wire. No, right? So we created a system called BANT. Now, the name BANT comes from Dr. Frederick Banting, who discovered insulin at Concordia, University of Toronto. And the system is completely wireless. So basically, an adolescent would prick their finger, take a blood glucose reading, that would wirelessly transmit to their phone, launch the app, and at which point it would plot it on a target. And then it would also show them trends and give them feedback. So if over a week they were having donuts every day for a snack and their blood glucose was sky high, it would say, hey, your readings were 3 times very high this week. What have you been doing? Something is up. So it's not passive, it's active. We also used some novel techniques. We included a social media component, which was Twitter. So we embedded a microblogger to see what would happen, right? Another interesting component is iTunes rewards. So we knew that, this still may not work. We need to have some kind of behavior change here. So we told them, if you're good, if you involve yourself in your care, we'll reward you with iTunes. So then we did a clinical trial. It was a small pilot, actually, of 20 adolescents for 12 weeks. And at the end, we saw that they improved their self-monitoring by 50%. So before they were only taking 2 readings a day, and now they're taking 4.8 readings a day, right? And a lot of it had to do with the iTunes rewards, but the social component was really interesting. We saw a little bit of competition happen, right? Because it was those 20 users that were on the Twitter account, and they were saying, hey, did you get a good reading today? What was your number? So we're trying to continuously leverage this to create really useful solutions for this target demographic, which is really important. Now, if you look at the countries we were able to reach, which is really significant, we weren't anticipating this. Korea is our #2 user group. How did that happen? The reason is we created it in 11 languages, right? And this was easy. We just went around the office, and there was all these people of different nationalities. But still, why Korea? Because in Korea, they do not have their own native language apps. Some of these other countries do because it's getting popular, but in Asia, there's still a little bit of a lack. They're not creating native language apps, which is significant. I'll quickly touch upon this, and something that's going to affect all of us very soon is type 2 diabetes. This is different from type 1 diabetes. So here we're looking at being sedentary, eating poorly. It's an overall lifestyle change, right? And this is actually the focus of my thesis. So if you want to talk about this after, I could talk your ear off. So we're looking at using the mobile phone and activity monitors to get people to understand their bodies better. So we want to track your behaviors. Have you been sitting in class all day, sitting in front of the computer all night, right? Have you been eating bad things? Have you been outside more? So we want to use the smartphone to really understand your behaviors and then motivate you to change them. Now this is a concrete example of some work we did with asthma patients. Very similar to the type 1 study I showed you before, they're using this paper-based action plan, which is posted on your fridge somewhere and forgotten about. So we went ahead and worked with the Ontario Lung Association to create an app that used a different technique called responsive design. Now responsive design doesn't restrict us to native apps. So native meaning iPhone specific, BlackBerry specific. This allows us to really work on any platform that can launch a browser. So think of the reach you can have. We are going into a trial now, so we'll see what the results of that is. So some quick features here, it allows you to see the day-to-day conditions, track your symptoms, and receive feedback from your provider. So now I've been speaking a lot about people who are sick and people who have conditions, but what about the rest of us, right? We worked with the Heart and Stroke Foundation of Canada to try to address this problem of invincible 18 to 35-year-olds, which I would say is the majority of this room, who don't really pay attention to their health, specifically when it comes to cardiovascular health. Only 9 out of the 10 of us, actually 9 in 10 of us have some kind of risk factor for cardiovascular disease. So that includes being sedentary, eating poorly, smoking, alcohol, salt, stress. So we're all going to be, yeah, somebody said, oh God, yeah. So we're all, that's basically all of us, right? So we followed the same user-centered process and tried to recruit different people from all over Toronto and understand how we could reach them through the mobile phone. And after doing some prototyping, we came up with this concept, and if you have an iPhone, you can download this. It's on the Apple Store. It's called 30 Days. And what 30 Days lets you do is take a risk assessment and understand what are your unique risk factors for cardiovascular disease. And we understand people don't have time to think about this. So this was a quick interaction. We wanted you to complete a task that was specific to your risk factors that would help you improve your behavior. And then as a kind of experimental addition, we included these badges, as you can see on the extreme left-hand side, which were just a way to be fun, right? People didn't want to take their health so seriously. So now this was really interesting. We launched this app last September, and we had over 74,000 users across Canada. And we are able to gather data from all of them. That's a lot of data. And this data is how they use the app, what they use the app for, how frequently. So it allowed us to really understand their engagement levels and whether or not our strategies were useful. Now I could give you all sorts of stats. This was a huge analysis, and if you're interested, we can speak afterwards. But some key things. We attracted 74% female users. That's weird. That was weird to us. We didn't expect that. And our feeling is that a lot of these female users are caring for not only themselves, but their families. Sorry, guys. I need to get more involved. And something else that was interesting was that they used Air Miles promotion. So again, this concept of gamification. So Heart and Stroke gave people Air Miles rewards for downloading the app. Right? So that also explains why the downloads increased from 300 a day to 1,000 downloads a day. And the Air Miles rewards were something like 20 points, which is equivalent to about $1, I think. Somebody correct me if you know. So overall, the conclusion of this story is that we got incredible engagement levels. There's still some work that needs to be done to understand how we can attract males who are 18 to 35 and get them more invested in their own health. And this is the last example. If there's any clinicians or healthcare people in the audience, we know that poor communication in the hospital environment is one of the leading causes of medical error. Just lack of communication between all the different physicians, the nurses, the pharmacists, right? This is especially true for patients who are dealing with up to 10, 15 doctors because they have 10, 15 conditions. So we are looking at using mobile health not only for users and patients, but in clinical environments, right? So this may look similar to another social platform, which is Facebook, because it's actually a book of faces. But it's a book of all of this physician's chronically ill patients. And he can click on this patient and see all the physicians involved, what their conditions are, the most trending topics, and make sure he's involved at the right point in time. Right? The issue with this is that every hospital has their own IT system. So it's really difficult to implement this as a turnkey solution. Right? Now, as I told you before, we're in a hub of hospitals, 4 hospitals, so it's easier for us to test these solutions. But a lot of thought needs to be gone into how these solutions can be really implemented on a national level with so many different types of networks. So as a conclusion, working this field has given me a lot of insight, specifically into the fact that there needs to be a consumer-driven initiative. We can't just create things without them actually being useful. So we need to engage with the people who have a gap in their workflow and address that gap using mobile health. And lastly, it needs to be social. A lot of these patients who are dealing with chronic diseases feel isolated. They're sent home after ER appointments and have no way of communicating with the outside world. So we can really use social media, text messaging, the internet to promote these type of behaviors. That's the end of my talk, so if you have any questions.